move to the next speakers, Dr. Maher Zghayar. Dr. Maher Zghayar, he received his MD degree from the Jordanian University, and he was trained in anatomy and pathology, clinical pathology in Harvard Medical Schools, hospitals in USA, and he has 3 American sport certificates, and currently he's working as a member and chairman in pathological department and laboratory in King Hussein. You're welcome, Dr. Maher Zghayar.
Thank you very much for the kind introduction. Let me start first by thanking the organizing committee, Dr. Abdessalam, Dr. Sufyan, Dr. Nancy, for inviting me to give this talk. It's really a pleasure to be back in my country, Palestine, to really share with you any experience or update that and I'm really, very delighted to see some of my ex-students and now currently they are my colleagues among the audience and the organizers. This is really very rewarding. It's been a really pleasure. Okay, so basically my talk is about management of solitary thyroid nodules, and for those of you who really want to get the nutshell or the final, take-home message of this talk, I will start with that because it's very easy. There is a solitary thyroid nodule. We do 2 things, ultrasound and fine needle. And based on the fine needle, there are recommendations what to do. That's it. Very easy, huh? Making life very easy and straightforward. So basically, thyroid nodules are very common. This is the outline of my talk. Okay. Now, there is a terminology that has been introduced into many cytology language to make things clear and easy. Now, for the thyroid, they have actually come up with the Bethesda based on the place of the first meeting of a group of experts in thyroid. I mean, including not only cytopathologists, but also radiologists and endocrinologists, etc. They met and came up with a common language and recommendations on what to do based on the findings. So basically, the most important test you do for a solitary thyroid nodule in a patient is fine needle aspiration. And that's where I am involved in this kind of talk. I mean, the management, because the cytopathologist will eventually give a recommendation. If the lesion is malignant, then it goes to surgery. If it's benign, it's followed up, etc., based on the recommendations. So prior to the use of fine needle aspiration cytology for thyroid, many patients with solitary thyroid nodules actually had unnecessary surgeries done for their thyroids. So that was a real problem. Nowadays, what people should do is really limit surgery, even cancers in the thyroid. Now the recommendations currently is to limit the amount and type of surgery. So this is really very, very important. You want to limit surgery that are really unnecessary. And so you can see that in terms of numbers, prior to thyroid FNA, only 14% of surgically removed nodules were malignant. But after the introduction of fine needle, it's now the incidence of the chances of a nodule being malignant removed by surgery is more than 50%, and actually the numbers are increasing. Okay, so what are the indications for a thyroid FNA? Nodules that are discovered by palpation or by physical examinations. Usually these are larger than 1 centimeter at least. Okay, what you do, you do your routine history and physical examination and serum TSH and thyroid ultrasound. Now, if the TSH is normal or high, we look at the ultrasound results to decide. If it is a simple cyst or septated cyst with no solid components, we don't do anything for the patient. But if there is a complicated cyst or a real solid nodule, then we have to do a fine needle. If the TSH is low, that means it's active, and the chances of the active being really, you do a thyroid radionuclide scan. If it is iso or hypofunctioning, then we look at the ultrasound results. If it is functioning, usually the risk is very low for that. Okay, what about thyroid nodules that are discovered incidentally, so-called incidentalomas? Anyway, they're usually discovered either by a PET scan or systemic scan. So if they are focally positive and discrete nodule by ultrasound, not multiple nodules, then there is a chance really ranging from up to 50% or 60% of being malignant. So then we do actually an ultrasound for the thyroid, and then we do a fine needle aspiration. If they are discovered through ultrasound that was done for a non-thyroid lesion, then a dedicated thyroid ultrasound should be done. If it is more than 1 or 1.5 centimeters, really varies about which reference you have. Then you do a fine needle aspiration on this. It's a simple cyst initially. Now lesions between 1 and 1.5 cm with benign features on ultrasound, you can follow these up. So what are the features that are not benign on ultrasound? Now that's not my domain, but I'm listing these features. I mean, you get an ultrasound done by an expert ultrasonographist, and then you get these features which are suspicious, so you have to know them. The presence of microcalcification, hypoechoic, solid nodule, irregular lobulated margins, intranodular vascularity, normal, nodal metastasis, of course, or signs of extracapsular spread. These are suspicious features on ultrasound, and therefore a fine needle aspiration should be done. Some people say with these features, any nodule of any size should be aspirated. Now this is controversial because many societies have different recommendations. So, because these features would include microcarcinomas, and the natural history of microcarcinomas is really very benign, and people think maybe we should not really do anything about those. Now, as I said, there are several guidelines. So the American Thyroid Association says any nodule more than 0.5 centimeter in diameter should be aspirated. If it is more than 1 centimeter in the absence of suspicious sonographic features, you should aspirate it based on the American, what's the society, ACE, I think it's here, written here, the American Association of Clinical Endocrinologists, and then you have the European Thyroid Association and the Italian Association, it's here, Association Medici Endocrinology. Anyway, if it is more than 1 centimeter, according to the NCCN guidelines, which is the most commonly used guideline, by the way, by the oncologist in the US, because this is the National Cancer Network, if it is more than 1 centimeter with suspicious sonographic features, we do a fine needle aspiration. If it is more than 1.5 centimeter without suspicious features, we do a fine needle aspiration. So incidental nodules on CT or MRI scans, there are few data on that, but you do a dedicated thyroid ultrasound, and based on that, we follow the criteria as above. Okay, so how do you do the fine needle aspiration? Do you do it, just by palpation or guided by ultrasound? Now, in the past, we used to do it, if it is large, we used to do it the pathologists ourselves, and also the endocrinologist would do it, the surgeon would do the fine needle aspiration. It is large and seen and easily palpable. But if the nodule is small and found by just ultrasound, then you have to do it under ultrasound guidance. Nowadays, when I trained in pathology, we used to do it just for those which are visible or palpable. But nowadays, pathologists are trained and they give courses actually on ultrasound-guided, fine needle aspiration. So pathologists have come into the field and they are doing ultrasound and doing FNA under ultrasound guidance, and actually endocrinologists as well are doing it under ultrasound guidance. So they are stealing the ultrasound-guided procedures from the radiologist. So there is a value for doing a thyroid ultrasound. It changes actually the management in 63% of patients with palpable thyroid nodules. It identifies nodules at risk that should be sampled and reduces the rates of insufficient and false negative aspirates. That's very important. Many of my colleagues, when they send the fine needle, they say, you always get us back the result as being inadequate, insufficient. So that's, maybe because we miss the lesion if we don't use ultrasound guidance. And then ultrasound specific findings can be used to inform the results of the ultrasound-guided fine needle aspiration, such as a cyst. Now, I'm not as any expert really in ultrasound findings, and I read the comments on these, but this is just an example of a well-circumscribed nodule. And this is an example of a very irregular nodule by ultrasound. There's a pointer here. So here's microcalcifications. This is papillary thyroid carcinoma by ultrasound, and then the fine needle aspiration, and then the histology. So a nodule more than 1 centimeter in size, palpation-guided FNA can be considered after ultrasound confirmation, but any nodule that is smaller, you have to use really ultrasound guidance. Ultrasound-guided FNA is acceptable and is preferred for nodules that are not palpable or more than 25% cystic of their size, or have been biopsied before and yielded a non-diagnostic result. That's what we will use. So the minimum data that should be supplied to the pathologist in order to really make a diagnosis, good diagnosis, this is what you need to supply us. It's a long list, but none of which is usually provided. So it's just a thyroid nodule. Okay, so optional data that can be also given: the result of TSH, the prior fine needle aspiration, results of ultrasound examination, and results of nuclear medicine if it was done. So as we said, we need a unified terminology that people know when you say it's category, for example, 1 in Bethesda classification. People immediately would know what does that mean. Category 6, okay, etc. Each category has its risk of malignancy and management. It's a pathway, it's a guideline. Anyway, it's very clear. So the risk of malignancy is in there, and this is called the Bethesda system for reporting thyroid cytopathology. So these are the 6 categories in the Bethesda system: 1 being insufficient for diagnosis, 2 benign, 3 etibia of undetermined significance or follicular lesion of undetermined significance, 4 suspicious for follicular or hairy cell neoplasm, 5 is suspicious for malignancy, and 6 is a clear-cut malignant diagnosis. So, and each of these has its own risk of malignancy. So when you tell the patient, your result has this, etibia of undetermined significance, this means that there is a chance that your nodule being malignant is 10%. And based on that, and the recommendation is to do X or Y. So that was a short, list, and this is the further or expanded categories of the Bethesda. As you can see in the non-diagnostic, it is only a cyst, which is just cystic fluid. There is a chance of there being a papillary carcinoma of the thyroid, so that's called non-diagnostic or unsatisfactory. So the benign is anything that's benign follicular nodule, Hashimoto's thyroiditis, or anything follicular. The etibia of undetermined significance, and then we have follicular neoplasm or suspicious for follicular neoplasm, because these things cannot be diagnosed cytologically, so it has to be either follicular neoplasm or suspicious for follicular neoplasm, then suspicious for malignancy, and then malignant. And that's just the updated 2017. So that the classification came out in 2008, and then an update was issued 2 years ago that included a new entity. Actually, it's not a new entity in thyroid neoplasm, but it was an old entity that was reclassified. Okay, we'll go over. So these are just general principles of the Bethesda classification, stating the category. Now, just briefly about each category. When we say non-diagnostic or unsatisfactory, this is 10 to 30% of thyroid FNAs usually. It can be quite high. And then, based on certain criteria, we decide whether it's adequate or not. The exceptions for that, if there is a specific diagnosis, a specific thing, finding like etibia or thyroiditis or abundant colloid, then we don't really call it insufficient. So this is an example of cystic fluid. You can see the picture of macrophages. There is a risk of malignancy, that being 4%, so that's why we call it non-diagnostic. Even if it was a cyst, just a cystic fluid, there is a risk of malignancy of 4%. The benign category, which is Bethesda category 2, usually includes benign nodules and chronic lymphocytic thyroiditis or Hashimoto's, and there is a false negative rate of less than 1%. And these patients can be just followed up. You don't need to do anything. Usually the cytological smear is really a very uniform single layer of benign looking follicular cells or abundant colloid, as you see in these pictures of colloid. And sometimes we get just intact macro follicles like this one, or just a thin layer of follicular cells. This is a smear from a patient with Hashimoto's thyroiditis. You can see the abundance of lymphocytes and hair cells in the background in these pictures. The ETB of undetermined significance, or follicular region of undetermined significance, basically here there are some suspicious features, but are not enough to call it suspicious for malignancy. So here we have to repeat the fine needle aspirations usually within 6 months. And there is a chance of this being malignant. The atypia could be cytologic, architectural, or both, or sometimes there is atypia related to vertex cell aspirates. There are criteria here mentioned that we follow as cytopathologists. You don't have to really, to worry about them now. Now, what's new in the thyroid pathology? We used to have an entity called encapsulated follicular variant of papillary thyroid carcinoma. And this variant of papillary carcinoma turned out to be, after years of follow-up, it behaves in a benign fashion. Okay, so they decided, an expert panel decided that based on this, data that were not available, to call this downgraded actually from being called malignant into being called a thyroid carcinoma. It's called NIFT-B, which is here, as you can see, non-invasive follicular thyroid neoplasm with papillary-like nuclear features. So this has been downgraded, so the New York Times has it on its front page saying it's not a cancer, doctors now say about this type of tumor. Okay, so this has changed actually the classification a little bit because it changed the risk of malignancy. Because when we see this entity on a fine needle, we used to call it either papillary carcinoma or suspicious for papillary carcinoma. Now it's not a carcinoma anymore, so I have to hurry up. Anyway, this is the most important actually part of my talk. This is the classification of nodules based on the Bethesda and their risk of malignancy and the usual management. So you can see the non-diagnostic unsatisfactory, the risk of malignancy if we remove NFP, this entity, from being malignant. Now the risk of malignancy for each category of the classification of the fine needle aspiration finding is, the first one is 5 to 10%, remains unchanged. The benign is 0 to 3%. So even the benign, there is a 3% chance of being malignant. And the TB of undetermined significance has been, down to 18%. And then if we say follicular neoplasm, there is a up to 40% chance of being malignant, suspicious for malignancy. So even if we say on a fine needle this is suspicious for malignancy, that does not mean it's going to be malignant, because only 60 or 60% now, based on the update, will turn out to be malignant. And when we used to say it's malignant, it used to be up to 99%, very specific diagnosis by fine needle. Now it has been a little bit less because of the NIFT-B, this entity that has been downgraded from being cancer to being non-cancer. So you can see, now the last column here, this is also very important. This is the usual management. This is what you do when you get this. This is unified language of thyroid cytopathology, fine needle aspiration finding, what to do with the patient. So this is the last column. This is the most important. So what you do, you repeat the fine needle for the first category. The second category, you do clinical and sonographic follow-up, which that's for the benign. The third category, you repeat fine needle aspiration. And nowadays, this is an update, people can do molecular testing and being practiced in the US. They take another aspiration and they do molecular testing, a thyroid panel. There are 3 companies actually making commercial kits that will tell you, based on the molecular finding, this is going to be carcinoma, remove. Based on the finding, that's benign, forget about it. And then also can be done on category 4 or lobectomy. So for us, for our situation, we don't have the molecular tests, which are very expensive. And in that situation, you do lobectomy and near total thyroidectomy for category 5 or 6, or lobectomy. So even for category 6, now the trend is to do lobectomy. Now I have, 5 minutes or less? No. So I'll just stop here, and thank you very much. That was
Thank you very much. هو بصراحه دكتور ماهر انه احنا عندنا فلسطين هنا في مشكله في الموضوع بصراحه في موضوع الباثولوجي، وانا مش عارف انه كيف ممكن نحلها. احيانا بيجينا احنا نتائج كاطباء ما بنعرفش حتى شو بالضبط نحكي للمريض على هذا الموضوع. الشغله الثانيه انه هل في قواعد انه لازم يكون تو باثولوجيست يوقعوا على التقرير ولا لا؟ لانه احنا مرات احيانا بنقول هذا الباثولوجيست وديعه هاي ولا بدي سكند اوبينيون، ولا لازم يكون يعني في قواعد عالميه المفروض انه نلتزم فيها كفلسطين هون احنا، لانه بصراحه بنواجه مشكله في هاي الشغله.
Okay. Now I see the question is very important. Now the current trend in general in the West for diagnosis of cancer is that it has to be really duly signed by two pathologists if you make a diagnosis of malignancy. In general, whether that's a histopathology or cytopathology. But that means that you have to have the luxury being in a big place with many pathologists working, and which is I understand is very difficult to come by. In my institution, actually, we do certain quality control measures. We do a random re-reading or re-diagnosis of 5% of all diagnoses, and we have fellows who are actually board-certified pathologists, sharing the diagnosis with the attending or the consultant. So you can say that two pathologists are usually looking at the cases, although the last word will be for the attending. And then we have a daily meeting for all pathologists or staff pathologists that review not necessarily just the malignant cases. I mean, I work in a cancer center, but most are malignant. But we do that for very difficult or interesting or cases that have problems. You have to do that. And then pathologists are the people who are very, very commonly seek their colleagues' opinion. So if you have enough colleagues in the department, they usually share, and you have some specialists who do certain kind of fields in pathology, some specialists in pathology. That will help in avoiding problems.
Any questions?
في موضوع الالتراساوند انا بحب الفت نظر الزملاء انه في صار كلاسيفيكيشن للالتراساوند اللي هو تايراتس 1 2 3 4 5 زي ما في البريست ايميجينج داتا سيستم. بتمنى انه الزملاء ياخذوا علم بهذا الموضوع وحتى يصير الكوميونيكيشن احسن بين الراديولوجيست والكلينيشن اللي هو الامريكان كوليدج اوف راديولوجي عملوا التايرات سيستم. بعتقد هذا يعني بعطي كرايتيريا للثايرويد ماسز.
Thank you. That's excellent. Yeah.
Because they're not following the system.
Radiologists, yeah. Thank you very much. Dr. Sadr is one of the well-known radiologists in Palestine. So yeah, this is very important. Very, very important point. Thank you for that.
Thank you, Dr. Maher. How much it take in practice between taking the sample and giving a report to the physician? Because in the beginning, when we started doing FNA in the outpatient, the answer was ready and available less than 20 minutes.
Yes.
We fix it in the outpatient, send it, read, and it comes. Now it takes 3 days.
Okay, this is the logistical question. I understand this is very important. This really depends on the type of practice. So if you have a dedicated cytopathologist sitting in an FNA clinic that's dedicated, he's sitting there all day waiting for the patients to come, and then you do it, and then he renders a preliminary, I probably should call it preliminary interpretation, so the patient can be triaged during a single visit. That would be very optimal. That's excellent. Yeah, it's being practiced in certain. But today, it's, I mean, if you're in a big department and there are very few pathologists, then you have to really, it takes 2 to 3 days because there's other components to this. You can do a cell block sometimes. That takes more than 1 day to be ready. And then sometimes you can do special stains. I'm not talking about specifically thyroid, but other fine needle aspirations. But the practice has been something called DROS, Rapid On-Site Evaluation, in order to make sure that it's adequate or not. At least we give adequacy for that. So if it's adequate, we tell the operator or the person who took the fine needle, that's fine, you've got enough material. If it's not, in order to not to call it inadequate, and the patient comes for a second visit later, so on the spot we tell them it's really not adequate, take another pass.
Thank you, Dr. Maher. Thank you.